Bismillah ar-Rahman ar-Rahim. My name is Ashraf Rojdi. I am an intensive care consultant in Barts Health in UK, Whips Cross Hospital. I am also a lecturer and consultant of intensive care medicine in Alexandria University in Egypt. Today, my lecture will be about coagulopathy in COVID-19. I will go rapidly through the pathophysiology, the epidemiology, the laboratory workup, and the treatment. I think this subject is quite complex and difficult. First, because of the complex pathophysiology, but also because we don't know much and there is a rapidly evolving knowledge about what is going on. There are numerous studies in the literature, but most of them are small studies, observational studies. So the quality of evidence is not very high. Before preparing this lecture, I did a rapid search just on PubMed, and I can find like 350 articles which delineates how important is this subject. So if we start by understanding the pathophysiology and the trigger for coagulopathy in sepsis in general. So it is for a long time that we started to understand that sepsis can induce coagulopathy up to GIC. And this is in particular because there is a relation between the inflammatory response and the coagulation system. To a point that this had been called immunothrombosis because there is a crosstalk between inflammation and coagulation, which can range from just subtle subclinical coagulopathy up to a massive form like GIC. This is part of the multiple organ dysfunction is sepsis because microcirculatory failure and microcirculatory thrombosis contribute to the tissue hypoperfusion. And this is mediated by pro-inflammatory cytokines, mainly the interleukin 6, but there are other interleukins and cytokines involved, which can activate the coagulation, but also downregulate the anticoagulant pathways. And all this is mediated on the tissue factor, but also inhibiting the endothelial anticoagulation. So if we go back like 15 years, this had been investigated a lot by many studies. Only one study of them had proved that there is maybe a benefit of targeting the coagulation to ameliorate the outcome of sepsis, which was called the PROUSE trial, which used the activated protein C, which is normally occurring anticoagulant, to ameliorate the prognosis of patient in sepsis. However, years later, there is another study, which is the PROUSE shock trial, which had shown that this benefit is not very consistent, which led to the withdrawal of the medication. But this gives us a hint that how much the coagulation and the pathophysiology of sepsis are interrelated. So what's the observation we had since the appearance and the emergence of COVID-19? So there was very evident hypercoagulability since the start, either as skin manifestation, but also when nurses, they withdrew blood, they said that blood is clotting. When patient run on a filter on continuous veno-venous hemofiltration, the filter clots very frequently. So there was a constant observation by everyone that there is a hypercoagulability state. And looking to the blood test, there was a notice and an evidence of a prolonged PG, elevated G dimer, elevated fibrinogen. The APTG is slightly prolonged. There are some case reports also about antiphospholipid syndrome, but very small case reports. And we know that the diagnosis of antiphospholipid syndrome, it needs to repeat the test after 12 weeks to confirm it. So we are not sure if it is a false positive or really inducing an immune reaction and antiphospholipid syndrome. GIC had been reported, and we'll discuss this later. And there is thrombocytopenia, but in fact, we can see a mild thrombocytopenia, not in all patients. So it is milder than normally what we see in septic patients. So we can see on this slide an early report by Chinese group showing that the survivors, they had much better coagulation parameters than non-survivors. So the abnormality in the coagulation was associated with the outcome, with poor prognosis, in fact. And if we look to the time course we can see that the G dimer in the non-survivors is increasing, but is not increasing in the survivors, in fact. And this correlates much with the interleukin 6 and the troponin. And if we combine this with the observation that 30% of CTPA showed PE, those are in suspected patients. 10% of ICU patients, they had PE and GVT, despite most of the ICU patients or all the ICU patients are prophylactically anticoagulated. Also, the experience coming from ECMO centers shows that there is a hypercoagulability and there is a frequent PEs. Observations that GVT may be less than PE, but we know that the way we diagnose GVT by Doppler may be less sensitive than doing a CTPA. And there was some reports also about ischemic stroke. This is a cohort study, an observational study from Italy, which is showing that cumulative rate incidence of 21% of thromboembolism in COVID-19 patients. And the incidence of ischemic stroke and acute coronary syndrome, which is more of arterial nature, was just 2.5% and 1.1%. The incidence of GIC over GIC, in fact, was reported just in 2% of patients, which gives the impression that it is very common to have patients with venous thromboembolism, less frequently arterial, but the over GIC also is not very common. But the alarming thing, when the authors they conclude that 50% of those patients they presented and they had been diagnosed with VTE on hospital admission within 24 hours of the hospital admission. So it looks like it is part of the pathophysiology of the disease rather than lines or prolonged immobility or other factors in the ICU. So the patients they present, in fact, and it seems venous thromboembolism is part of the pathophysiology of the disease. So my personal experience that there was many patients, in fact, in the intensive care with pulmonary embolism. The incidence of we lose filters, renal replacement filters was very high, in fact. We had many patients with MI confirmed by high troponin, ECG changes, and echo changes. And most of them are type 2 or non-ST segment elevation MI, but personally I had seen 2 inferior ST segment elevation MI. I had seen 2 patients positive on HET screening. One had not been confirmed, turned to be negative after. And the incidence of stroke is yet to be confirmed. So how COVID-19 can cause this coagulation problem? So looking to the pathophysiology, it seems that the SARS-CoV-2, the virus itself, the coronavirus itself, by the damage-associated molecular patterns and the pathogen-associated molecular patterns, it activates the monocyte to express tissue factor. And these activated monocytes and the activated endothelium also to express tissue factor activates the extrinsic pathway of coagulation, which attracts the neutrophils, which start to activate the platelet and activate at the end the other coagulation pathways. Also, the normally occurring anticoagulants are suppressed in COVID-19. So there are, in fact, 2 other factors which can add to the pathogenesis of the thrombosis in COVID-19. First, this study which had shown that there are viral particles in the endothelium. So there is endotheliitis, and we know that the endothelium can express the tissue factor and can contribute to the thrombosis in those patients. Another thing which started to be known for the last years is that the hypoxia itself, by inducing the HIF, hypoxic-induced factor, can induce thrombosis. And we know that those patients COVID-19, because they develop hypoxemic respiratory failure and they are very hypoxic, which can contribute. So apart from the sepsis itself and the SARS-CoV virus, which induce the tissue factor on the monocytes and the endothelium, there is a factor of endotheliitis and there is a factor of hypoxia also. And this can contribute, in fact, to the notion that there is less DVT in fact than PEs, so we are not sure if it is a local thrombus in the pulmonary vessels or it is embolism coming from the lower limbs. And this had been suggested by the Italian authors, and they suggested that doing direct CTPA may be a more practical approach than doing ultrasound because the CTPA looks like more sensitive. But of course, doing the CTPA requires the transport of patient and the risk of contamination, which is an added risk for the hospital and the strained resources. So a group of authors, in fact, they suggested or hypothesized that maybe the immune mechanism can cause what they called pulmonary intravascular coagulopathy rather than the disseminated intravascular coagulopathy known as GIC. So they hypothesized that the hypoxia and the inflammation, in fact, by many mechanisms can induce local thrombus and local intravascular coagulopathy in the pulmonary vessels through the immune response and the alveolar damage and the interstitial inflammation and the macrophage activation, but also by the mechanical ventilation itself. And they suggested the difference between the PICs, the pulmonary intravascular coagulopathy, and what we know like GIC. In fact, this should be confirmed by further studies, but it had been suggested also in this review article that this coagulopathy contribute to the pathophysiology and contribute to the phenotype suggested by Professor Gattinoni, that patients hypoxic early with normal compliance, what is called the phenotype L. So they have a normal compliance and they don't have the classical ARDS picture. So the hypoxia here may be related to VQ mismatching and pulmonary thrombosis even in small capillaries of the pulmonary circulation. And then this is phenotype L, and then phenotype H, the hypoxia is more related to the ARDS. So maybe the coagulopathy early, because it had been shown in the Italian study, patients they come early with coagulopathy. Maybe this is the pathophysiology of the early hypoxia. All those are theories and are not confirmed yet. So considering the autopsies which can maybe confirm and give us more histopathological diagnosis, we can see that venous thrombosis is very common. This is a cohort of 12 cases had autopsy after death, and we can see that thrombosis is very common and mostly in the veins and in the pulmonary veins, but also the prostate venous system. There was a frequent thrombosis there. And most of those patients, if we can see that it seems that it is a major risk factor, that this thrombosis comes on top of atherosclerosis and chronic endothelial disease. And we know that patients with hypertension and diabetes and obese are high risk patients for having a severe COVID disease. And you can see in the same 12 patients that PE, there was PE in 4 patients of them, so about 1/3 of the patients, and it is the cause of death in those 4 patients. But also we can see that every PE was associated in fact with DVT, which can maybe contradict the notion that maybe it is a local thrombus, because all of those patients they have in fact DVT also. So the range of the coagulopathy is not just venous, it is a continuous spectrum, in fact, arterial, which can present like stroke or acute coronary syndrome, and venous, but most importantly also there is a localized intravascular coagulopathy, which can lead to microcirculatory failure and microthrombosis and can contribute to the multiple organ dysfunction in those patients. Coming back to the GIC, most of those patients, in fact, they will not score very high on the GIC score to be able to make a diagnosis of over GIC, because most probably they have mild thrombocytopenia, and many of them, they have normal platelet count. They have a very high G dimer, a mild prolongation of the PG, but the fibrogen is very high also. So if you sum the score, most of them, they will not have a score of 5 or more to be able to diagnose them as an over GIC. There is also what is called the sepsis-induced coagulopathy, which is another score which we can apply. But more importantly, we should look to the GIC and sepsis-induced coagulopathy as look to it in a dynamic way, because the patient in sepsis, they start to have some adaptive hemostasis, and then they have a GIC, most probably thrombotic, and leading to consumptive coagulopathy, and then they go into a fibrinolytic GIC. And this can affect our decision how to treat those patients. So if you look to the GIC that way, in fact, we can say that most of them, they may have GIC, but surely if we look to the over GIC score, like the Italian study, just 2% of patients, or very little percentage of those patients, in fact, they have GIC. The other thing which had been raised early is the HLH, the hemophagocytic lymphohistiocytosis. And again, there is a score to diagnose those patients. It is not that HLH can occur secondary to infection, most probably viral, but also in patients with malignancy and other causes. But there is a score, in fact, called the H score, and most probably we need a cutoff on 169 to diagnose those patients. And if you look again to the score, most of those patients, they will not they will not score high on the H score, because most of them, they are not immunosuppressed. They are pyrexic, but most probably they have no organomegaly. They have anemia like most of ICU patients, mild thrombocytopenia. Their ferritin, in fact, is not extremely high. It is in the mild form. I had seen numbers like 3,000, 4,600, not in the 10,000s, in fact. Their fibrogen level, in fact, is high. So most probably, if you look, they will not score more than 100 points. So I do not think personally that HLH is that common. It can occur in some patients, but it doesn't look like very common. So to sum up, COVID-19 associated coagulopathy is common and has a clinical impact because it is contributing to the hypoxia, it is contributing to the mortality. It is, as we had seen in the autopsy study, PE is the main cause of mortality. It is secondly to a very complex pathophysiology, partially related to what we know about sepsis, induced coagulopathy, and immunothrombosis. But also it seems that COVID-19 itself has a specific pattern to affect the endothelium and other patterns, other specific pathophysiological patterns. This needs a very dynamic interpretation and management, and it seems that over GIC and the HLH, both of them are not very common. Coming to the most important point, which is the management, the treatment. Early studies from Chinese had shown that patients who received heparin had a better prognosis than patients who didn't receive heparin, especially when the D dimer is very high. But these numbers and the studies should be taken with caution, because as we can see that most of the patients, like only 20% of patients had a prophylactic anticoagulation, received heparin. Most of those patients are ward patients. There are also studies showing that patients who received therapeutic anticoagulation, treatment dose anticoagulation, may have a better mortality, especially if they are mechanically ventilated. And there is a suggestion that immunological treatment like IVIG and low molecular weight heparin can change the viral nucleic acid and interfere with the pathogenesis of the disease. And it had been suggested that we should risk stratify the COVID-19 patient and treating them with VTE prophylaxis or anticoagulation accordingly. So the guidelines, there are two guidelines I will present. This is the international guidelines and the British guidelines. The international guidelines is more targeting patients in the ward. They suggest things we do for all ICU patients: monitor platelet, PG, G dimer, prophylactic low molecular weight heparin for all patients, including non-critically ill patients, and to tolerate a platelet down to 25 to give prophylactic anticoagulation. If the patient are bleeding, you should keep the platelet above 50 and fibrinogen more than 1.5 gram per liter and PT less than 1.5. The British guidelines for COVID-19 patient had admitted that many factors can predispose to thromboembolism in those patients, and that the abnormalities in coagulation is common and associated with poorer outcome, and there is an increased incident prevalence of VTE in those patients. Based on one study, they mentioned that the thrombotic complication in COVID-19 ARDS patient is much higher than non-COVID-19 ARDS patients. So thrombotic complication is like 2 to 3 times as we see in non-COVID-19 ARDS patient, but PE is 6 times more common. So they suggested that we should image patients to diagnose the PE, but because this sometimes is very difficult because of the many logistics and the risk of transmission of the infection, that a presumptive diagnosis of PE can be made, but they suggested to triage patient according to a bleeding risk score to see which patient we can give them higher dose of anticoagulation if they are low risk of bleeding without imaging, and which patient, because they have a high risk of bleeding, that should image them. In the absence of definite published data, they cannot make a particular approach, and they suggested to follow a local protocol. And they suggested a possible approach based on the risk for every patient, either the standard prophylactic dose or what is called now the intermediate dose of low molecular weight heparin, which is an intermediate dose between the prophylactic and the therapeutic dose. And of course, in patient with proven or suspected acute VTE, they get a therapeutic anticoagulation. They suggested and they recommended close collaboration with the hematologist, giving the prophylactic doses of anticoagulation down to platelet count of 30,000, and that the minor prolongation of PT and EPT up to 5 seconds is not a contraindication for prophylactic anticoagulation. Those patients who were on therapeutic anticoagulation before admission to the ICU should receive therapeutic anticoagulation. They raise the awareness about there is some interaction between the antiviral treatment and anticoagulation. There is a bit of theoretical advantage of giving heparin because it can bind to the SARS-CoV spike protein, but all this is very theoretical. And they suggested if a patient on therapeutic anticoagulation to switch into to direct oral anticoagulant on discharge. So over the next slides, I will show you some local protocols. This is the protocol from King's College, and they give, if you can see, they give a low molecular weight heparin, enoxaparin, in a weight-adjusted dose. So patient, for example, between 50 and 100 kilos, they give them 40 milligram subcutaneous enoxaparin BG, which is double what we're used to give. This is another protocol from Barts Health, and they stratify patients not just by the weight and their creatinine clearance, but also by the D-dimer. And this is a very common practice, in fact, now in many hospitals in many countries. Either you go with D-dimer, but the cutoff differs from a place to place. Some places they say less than 1 milligram per liter, more than 1 milligram. Some hospitals, the protocol is based less than 3 and more than 3, and there are protocols less than 1, 1 to 3, more than 3, and there is a protocol to follow. And this is the protocol from Guy's St. Thomas's again. And this is what we call the extended thromboprophylaxis, because there is some indication that those patients, they may have some prolonged hypercoagulability. So in patients with COVID positive, and they had inpatient VTE thromboprophylaxis, and they are anticipated to have a reduction in mobility on discharge. They recommended 2 weeks of apixaban or rivaroxaban or enoxaparin. And the duration and the dose differs from place to place because, as I said at the start of the lecture, that the evidence is not very strong and all those are local protocols. The take-home message is that COVID-19 patients are at high risk of VTE, and this is clinically very important because PE can be a major cause of death in those patients. Anticoagulation is mandatory for all hospitalized patients, and there is an argument for intermediate dose, a dose between the therapeutic and prophylactic dose for those patients. There are many local protocols guided by the weight, the renal function, bleeding risk, and G-dimer. It seems it is a multi-system affection, multi-organ affection, but there is an argument that maybe the lung vasculature and circulation may be affected more because of some local factors related to the ARDS and the inflammation itself, but this awaits further confirmation. There are different coagulation abnormality patterns on the lab possible, and liaison with hematology in difficult cases, I think, is mandatory. Continue to monitor patient. If you have thromboelastogram, may be of more benefit, but there is no study confirming that it can ameliorate the outcome in those patients. Image patient, if you cannot send them for CTPA, CT pulmonary angio, you can do them bedside echocardiography, look to the right ventricles, pulmonary artery pressure. We have very little data now and very little number of studies. Most of them are case reports or observational studies. So there is no much RCTs, randomized controlled trials, to make a definite plan for management. And the most important thing is that this is a continuously evolving subject, and I'm sure that there will be more evidence and more updated guidelines and recommendation in the next few weeks. Thank you very much for listening.